started your timer and here is your question. Right, so if you have read and understood, considering that surgical pathologist patient, kindly tell me what differential diagnosis would you consider for this patient?
There's differentials like giant cell arteritis
Yes.
or any intracranial space occupying lesion, maybe also DD.
Yes.
Or and optic neuropathy
Okay.
due to any
Yes.
other cause.
Yes.
Or retinal artery, central retinal artery occlusion due to any other cause.
All right. First of all, your primary provisional condition was giant cell arthritis. Can you define the term? How would you describe it?
This is an inflammatory condition of large and medium vessels, mainly of head neck region.
Yes.
Commonly the branches of external artery.
Yes. What is the most serious complication then that can arise in this condition?
Transient blindness. That may be a great consequence.
Transient normally occurs, but the likely complication is the occlusion of ophthalmic artery. So if you can tell me the epidemiology, in what age group does it appear?
Maybe fifth decade.
Sorry?
Fifth decade is the common age.
It is more common in females as compared to male. 2:1 is the ratio, and females more than 55 years of age. How do they appear? How do they present? What are the signs and symptoms?
They may present with a temporal headache.
Yes.
On chewing food.
Yes.
And transient loss of vision.
Yes, could even be fever, could be tenderness, severity, sensitivity on the scalp, jaw,
on the
claudication, yes, tongue, reduced visual acuity. Right. Okay, can you tell me, can you explain the mechanism behind it? If you'll do the histology or if you'll do the MRI of the patient, how would the patient present?
Yes, ma'am. First of all, tunica intima thickening will be that will cause that may cause thrombosis.
Yes.
And involvement of tunica media very resulting due to granulomatous inflammation.
Yes. Resulting in infiltration of which cells?
Infiltration of T cell and macrophages. And macrophages may turn into giant cells.
And which interleukins are most commonly seen in this condition? Can you name few?
Sorry, ma'am.
Okay, the interleukin 6, interleukin 17, and interleukin 21. All right, what are the labs that you can do to confirm your diagnosis?
I can do an ESR, ESR may be raised.
Yes.
And confirm my diagnosis, temporal artery biopsy.
All right, how likely or how credibility would you give to the biopsy of the temporal artery?
It's confirmatory.
It's not confirmatory. It's 50-50, 50%. Okay. If you can tell me which part of the vessel is most commonly affected and why?
Most common tunica media is informed.
Yes. All right. If you can describe the changes, the microscopic changes that you'll see.
The elastic laminar fragmentation is found due to granulomatous inflammation of tunica media
Yes.
and their infiltration of T cell and macrophages. Giant cells
Okay.
are found, rarely found granuloma.
Can you name
And
the T cells which are most commonly seen?
CD4 mainly.
And yes, mostly CD4 as compared to CD8. Okay. Can you name one simple blood test that can be done to which can signify this condition?
Yes, sir.
ESR, yes. Okay, right. If you can, if you can tell me what possible management can we suggest for this patient?
I will manage this patient by oral corticosteroid,
Okay,
prednisolone, 60 milligram per day,
yes,
or IV methylprednisolone. If there is transient evolving visual loss, I will continue for 2 years.
patient is an elderly lady. So what are the complications that you would keep in your mind while writing or prescribing corticosteroids?
Due to long-term use of steroid, it may
Yes,
result in osteoporosis or avascular necrosis of
yes.
this
If you can describe what is pathological fracture or pathological changes that occurs in case of osteoporosis?
In case of osteoporosis, there are decreased normal bone in quantity, and the due to the patient may be postmenopausal, it will cause more osteoclast activation and less osteoblastic activity that will ultimately result in osteoporosis.
Okay. Can you name few other conditions that can result in pathological fracture other than patient taking corticosteroids?
Other than corticosteroids, there may be some primary cause like postmenopausal patients
Yes,
or
and
idiopathic or senile cause, and some
yes,
secondary causes like metabolic causes are hyperthyroidism,
we don't
hypothyroidism.
give them corticosteroid like if it's skeletal metastasis or if there is Paget's disease, multiple myeloma, or if there could be any secondary metastasis somewhere like and in the conditions, bone conditions like rickets and osteomalacia, etc. Okay, can you please tell me what would you keep in your mind when or how would you manage the patient which presents to you with pathological fracture and you have to give them corticosteroid?
If I have to give them corticosteroid, then
How would you manage that patient?
to prevent the complications, I will give the general management like DVT
What is the
profile.
most likely complication that you can think of?
Sorry, ma'am, push that I
Fat,
didn't understand the
fat
question.
embolism can occur if
Yes,
there
ma'am,
is, yes.
yes.
So
Yes.
how should that be managed?
In
Or
case of
why fat embolism occurs?
due to long bone fracture is the common
Yes,
cause.
yes. And patient is elderly, would be bedridden, yes. And
Yes.
taking corticosteroid and
Steroid,
this,
chronic steroid therapy.
yes, there is chronic condition as well going on.
Yes.
Okay. So what else? How would you manage that patient?
In that case, I will give supportive management like respiratory management, oxygen, supplementation, mechanical ventilation may be needed, and
Yes,
supportive fluid and electrolyte imbalance should be corrected, and
yes,
general management like DVT prophylaxis, sepsis management, infusion therapy,
yes.
and these are the common management. Specifically, heparin can be given.
Heparin can also be given. Very good. Most importantly. So these are the things that you have to keep in your mind. Right. Okay, we'll end here. Thank you.